Webcast is now starting. All attendees are in listen-only mode.
Hi everybody, good afternoon, and thank you for joining us today for our educational webinar. Today's topic is Medicare Physicians Update and what's new for 2014. Before I introduce our guest speaker, I'd like to remind everybody that everybody will be muted throughout the webinar, so if you have any questions that come to mind, you can use the questions interface on your GoToWebinar tool. And at the end of the webinar, we will field the questions and Dr. Thompson will be able to provide answers. So let me go ahead and introduce Dr. Betsy Thompson, Chief Medical Officer with CMS Region IX. She's going to present an overview today again on Medicare bonus programs in 2014, along with some insight on the new Medicare fee schedule. Any questions you have for Dr. Thompson regarding Medicare's Meaningful Use Stage 2 and PQRS programs are welcome. Dr. Thompson is board certified in internal medicine and preventive medicine. Throughout her career, Dr. Thompson has been involved in many local, regional, and national initiatives focused on improving the quality of healthcare. At CMS, she serves as the principal liaison to professional organizations with respect to quality improvement and health reform. Welcome, Dr. Thompson.
Thank you. And thank you to all of you who are taking time out of your busy day to join us. So when I talked to the folks at Physician Partners, I asked them what they wanted me to do or what they wanted me to cover. They had this very short list of 4 topics. There we go. Well, really it was 5 topics, and I said, well, how much time do I have? Because usually each of these is about an hour unto itself. So we're going to go fast. I am going to mainly focus on the highlights of what's changed, as well as what I think you really need to know for 2014 and perhaps a little bit of crystal ball gazing into the future. So we'll be talking very briefly at a high level on these. I realize that some of you may know a fair amount. Some of you may be fairly new to one or more of these. So if you're new, hold on to your hat. I'm going to give you a lot of resources for each of these at the end where you can get more information, as well as our contact information, so that you can come directly to some of us in the regional office if you have specific questions that aren't answered on our website. So first I'm going to talk about the Physician Quality Reporting System and the Value Modifier. Now these are 2 different programs, if you will, that came under different legislation, but they are really joined at the hip, and that's why I'm going to talk about them together. I hope that many of you are already participating in the Physician Quality Reporting System and have received an incentive in the past. If you have not, I really urge you to do it now. This is the time. Don't wait any longer. The PQRS program actually began as a voluntary program in 2007, and as the name implies, it really is paying, it's an incentive program and now a payment adjustment program for reporting, not necessarily how well you perform, but the ability to perform. This year, eligible professionals and group practices who satisfactorily report via PQRS will earn a 0.5% incentive payment. This is the last year. 2014 is the last year for the incentive. In addition, I want to mention that if you have physicians that are participating in a maintenance of certification program, a qualified maintenance of certification program through their specialty board, that they will also be able to receive an extra 0.5% incentive if they qualify. When I talk about the percentages, the 0.5% or later on -1.5%, that's all related to the physician fee schedule allowed charges. So as I said, 2014 is the last year for the PQRS incentive, and in 2015, their payment adjustments, the word we like to use for penalty, kicks in. The 2015 payment adjustment is going to be a -1.5%, and it is based on participation in 2013 PQRS. So if you didn't participate last year and you didn't get, there wasn't an exception that applied to you, you will have a payment adjustment in 2015. This is the year you need to do something, 2014, to avoid the 2016 payment adjustment of -2%. That's why I said the time is now to start if you haven't already. Now, the value-based payment modifier actually came through the Affordable Care Act, and it required CMS to modify payments under the fee schedule that based on both the quality of care furnished as well as the cost of that care. This is very new. Many practices aren't aware of it. That's why it's so important to be talking to you today. We are phasing the value modifier in. We had to begin it by statute by 2015, and we have to phase it into all physicians or nearly all physicians by 2017. And the way we decided to phase it in was that in 2015, it's only going to apply to the physician payments for groups that have 100 or more eligible professionals. In 2016, we've already clarified in a final rule that it will be applied to payments for groups with 10 or more eligible professionals. Now, eligible professionals don't necessarily just mean physicians. It can include nurse practitioners, etc. 2017, though, as I already said, the value modifier will be applied to almost all physician payments, and it is based, at least for now, on participation in the physician quality reporting system. The next two slides go through the finalized policies related to the value modifier for 2015 and 2016. I'm not going to spend a lot of time on these. I can make these slides available to you so you can look at them. But part of it is what we've already talked about in terms of group size and performance year. It goes on to talk about the mechanisms you can use to do reporting, what outcome measures will be included, as well as patient experience care measures. Those will be added in 2016, well, for the 2016 payment year, which is the performance year of 2014. The cost measures are listed, as well as how the benchmarks are established, and then there's discussion of quality tiering, and I'll talk a little bit more about that in a minute. Quality tiering is optional for the 2015 payment adjustment. It is mandatory for groups of 10 or higher in 2016. And the payment at risk in 2015 is up to -1%, and in 2016 up to -2%. So thinking about PQRS, I hope, like I said, most of you are already participating. If you aren't, you first need to think about whether you're going to participate as an individual or a group. If you're in a group, how many eligible professionals are actually in your group? Individuals have a number of different ways to report. One is via claims. We still get an awful lot through that way, through claims. If you choose that, you are stuck with using individual measures as opposed to measure groups. But you can also use to choose a qualified registry, a direct electronic health record product that is a certified electronic health record. You can use a EHR submission vendor that has a certified product. That's for individual measures only. Or there's a new way, which is a qualified clinical data registry that may include not only PQRS measures, but certain other measures selected by that registry. These are brand new, so we don't know if entities are just applying now to be a qualified clinical data registry, but we're assuming there'll be some specialty groups and others that have been in the business of collecting quality data for their members for a while that would come in under that new option. So I wanted to walk through real briefly. I think this might help a few of you that are still getting started with this, figure out what steps you need to take and what it's going to mean in terms of both the PQRS and the value modifier incentives and payment adjustments. So if you're in a smaller practice for either individuals or groups of 2 to 9, first question to ask yourself is whether or not you met you're going to meet the 2014 PQRS incentive criteria. If yes, then all the EPs, as I mentioned earlier, in that group would earn a 0.5% PQRS incentive, as well as potentially another 0.5% if they are successful in their maintenance of certification program. You also would avoid the 2016 PQRS payment adjustment. If you're not going to meet the 2014 PQRS incentive, then there's another question you want to ask yourself, which is, did you at least do what you needed to do to avoid the 2016 PQRS payment adjustment? Because you can avoid the payment adjustment even though you maybe didn't do quite what you needed to earn the incentive. If you did do that, then you'll avoid the 2016 PQRS payment adjustment. But if you didn't, you will, those eligible, skipping over my words there, those eligible professionals will be subject to the 2016 payment adjustment, which for PQRS in 2016 is a -2%. None of these individuals currently have to worry about the value modifier because they're in groups of less than 10 EPs and they're not subject to the value modifier in 2016. However, they will be in 2017, so need to be prepared. I'm guessing we don't have too many folks that are in groups of 10 or more eligible professionals on the phone, but I do want to go through this because I know we may have one or two. First, do you plan to report for PQRS in 2014? That's the question you want to ask yourself. If you're not reporting even, then of course you're going to be subject to the 2016 PQRS payment adjustment. That's at -2%. But they will also be subject to the 2016 value modifier of another -2%. So that's a total of -4. If they do plan to report in PQRS, they have the choice how to do that. If they plan to report as a group, then they need to meet the criteria for the PQRS incentive criteria, the group incentive criteria. If they do meet those incentive criteria, again, they'll earn the PQRS incentive, possibly the maintenance of certification, and they'll avoid the 2016 PQRS payment adjustment. If they don't meet the PQRS incentive criteria for 2014, the question is similar to the last group. Are they going to do what they need to avoid the 2016 payment adjustment? If yes, they'll avoid that. If not, then they're back in that same boat over here where I don't want to see anybody in California on the right where they're getting both a -2% PQRS and a -2% value modifier. Now, if the group does not report as a group, they can still report as individuals, but the group has to meet the 50% threshold that the reporting occurs for the measures for 50% of the eligible population. If they do that, then again, they'll avoid the 2016 payment adjustment. If they don't, they're going to get hit with both the PQRS and the value modifier downward adjustment. Now, for all of these groups, if they're, well, not all of them, but if they're in a group of 10 to 99 eligible professionals, in 2016, they could be subject to either an upward or a neutral value modifier adjustment. So they could actually get a bonus, or they could be held harmless, basically. If they're in a group of 100 or more eligible professionals, this is where the quality tiering comes in. I'm not going to have time to go into that in detail, but based on their performance in terms of both cost, so resource utilization as well as quality, they could either get an upward adjustment, a bonus, they could be held neutral, or have a downward value modifier adjustment. I think I have a slide that sort of depicts this in a minute. One thing you'll want to do if you haven't done already as you get ready for this, particularly any of you that are in large groups, is access what we call your QRUR reports, the Quality Reporting Utilization Report, on our website. I have the instructions here to get you started, but you want to look at those because even though the data, you'll have 2011 data available now, that still gives you an indication of where you would score if the value modifier were live today for your practice. These are the sort of things that are on the performance highlights page. It actually gives you a quality composite score, a cost composite score, a score of your beneficiary's risk, your patient's risk, how sick they are compared to other Medicare patients. And then this quality tiering performance graph that's right here, number 4, that's what tells you where you would land if the value modifier applies to your practice now. How you score compared to all others. And if you're in that middle section of this kind of yellow cross, that's where you're average. So you're not going to be subjected to an upwards, you wouldn't be eligible for an upwards or subjected to a downward payment adjustment. That's also depicted really down on number 5, where it says what your payment adjustment would be, totally based on that quality tiering in the graph above. So for this individual, that little red dot there in the middle, they would be held at 0%, no increase, no decrease if the value modifier applied to them. And I apologize that I'm flying through this. It's a lot, I know. There are a list of important dates here for PQRS and the value modifier. Most of these on here aren't really you don't need to worry about submitting for a qualified clinical data registry or for maintenance of certification. That's for the entities that want to be such things, not for the individual practices. But February 28th is the last date to submit your 2013 PQRS data through certain reporting methods, as well as your Part B charges that would be included in the calculation of your incentive payments for both PQRS and the e-prescribing incentive. So those are big ones to know about there. Now, e-prescribing, I'm going to go through really quickly because you will be relieved, I hope, to know that this program is going away. You know, we really are trying to harmonize these programs and make it a little more, I can't say seamless, but a little more seamless than it currently is. This is what happens, though, when things occur through separate legislation as you try to bring them together. So this came about in 2009, and 2014, there is no further incentive, but there is a -2% payment adjustment this year. And what you needed to do to avoid the payment adjustment, your time frame for that has already passed, so I'm not really going to spend much time on that. Basically, though, you needed to have been a successful e-prescriber, or if you're not a physician, nurse practitioner, or physician assistant, those are the only 3 professional groups that are subjected to the e-prescribing payment adjustment. You could have submitted one of 3 codes that's during the period before June 30th of 2013 that indicated that you didn't have the capabilities locally to do e-prescription. If you filed fewer than 100 claims during the first 6 months of last year, that is eligible claims, or if you had less than 10% of your Part B fee schedule allowed charges that were eligible codes. And finally, if you reported a significant hardship code, and we determined at CMS that the hardship applies. Those were all ways to avoid the e-prescribing payment adjustment. I hope that if you weren't a successful e-prescriber, you did qualify under one of those. Moving on to the EHR incentive program, the first 2 slides just kind of show where you are. This is for the Medicare EHR incentive based on what year you began your first demonstrated meaningful use and where we are now. So, for example, if you first demonstrated meaningful use in 2012, you look on the left-hand column there, you find 2012, go over to 2014, and this year you would be in stage 2. That's what the 2 means in the blue part of this slide, and you could earn a maximum of $8,000. So this again just tells you where you are, what you might expect to get in terms of monetarily, and also what stage you're in, which is the 1, 2, and 3 at the top of each of the cells in this slide. For the Medicaid eligible professionals, it's a little simpler because whatever year you start in, the payments are the same from there on out. Payments are made over 6 years. The years don't have to be consecutive as they do for Medicare. And 2016 is the last year that Medicaid eligible professionals can begin participation in this program. I went back to the Medicare slide because this reminded me to tell you that 2014 is the last year to begin participation under the Medicare EHR incentive. But as I said, you have until 2016 in the Medicaid program. There were some changes between stage 1 and stage 2. I'm sure we have people on the phone that are in 2014 or in both of these stages. They really weren't huge. The total number of objectives for eligible professionals remained the same, but instead of 15 core objectives, there are now 17, and instead of 5 out of 10 menu objectives that you choose, there are 3 out of 6. There are other changes. Again, we're going through these at a very high level, but that diagram's the principal changes. I do want to spend a minute on payment adjustments because if you're eligible to participate in both Medicare and Medicaid incentive programs, you have to demonstrate meaningful use. So this particularly applies to folks who maybe are at a point where they're just attesting under, or not attesting, where they're doing AIU, that is, attesting or upgrading, adopting, or implementing a system, which your first year under Medicaid, that is sufficient, but that is not demonstrating meaningful use. So as we get to the payment adjustment period, you don't want to just be doing that AIU, adopting, implementing, and upgrading. That will not cut it. I wanted to make that clear in case we have anybody that might apply to. These slides are a little complicated, but I'm going to tell you what they really demonstrate. First of all, the payment adjustments are set to vary based on what percentage of eligible professionals are meaningful users in calendar year 2018. We are really hoping that there will be more than 75%, and we're encouraged with participation to date that it's not us meeting it, but that all of you will meet that. If it's less than 75%, you can see that upper table demonstrates what the payment adjustment would be. It could go up to 5%. That's a minus 5%, in addition to the PQRS and value modifier. If there's more than 75%, it starts out with both of these scenarios at a 1% decrease in 2015 and 2% in 2016. Where it differs is in those out years. And if more than 75% are participating, then the maximum payment adjustment would be a minus 3%. So I hope that's where we end up. These slides, really the bottom line, these are even more complicated, I think, to follow, but all they're telling you is based on when you first demonstrated meaningful use, what the EHR reporting period will be for each payment adjustment year. So the first table there is if you first demonstrated meaningful use in 2011 or 2012. The next table is if last year, 2013, was your first year of demonstrating meaningful use. And this final slide is if you are demonstrating meaningful use this year for the first time. There are, like many of our programs, a number of EHR hardship exceptions that you can apply for. I'm not going to read these to you. You can read them, and hopefully you all know about these already. One change that had happened, I think this was last year, is that certain specialties of anesthesiology, radiology, and pathology specifically do not have to apply for the hardship exception. If we have data showing that it's in July 1st of the preceding year of the payment adjustment year, so for 2015 that would be 2014, if you are registered in one of these specialties with us, you will automatically receive a hardship exception based on that one criteria that was if you don't have face-to-face or telemedicine interaction with patients and you don't have a need to follow up with patients. One important change that we just announced in terms of EHR milestone dates, February 28th had been set to be the last day to attest to meaningful use for the 2013 Medicare EHR incentive. We just pushed that out to March 31st for eligible professionals. So that was just announced in the last week, and I want to make sure you know that so you have a little more time to attest to meaningful use if you haven't done so already. June 30th is the last day to apply for an exemption to avoid the 2015 payment adjustment. So if one of those hardship exemptions applies to you, don't miss that date. And July 1st, 2014 is a little different. If you've been following this at all, everyone is doing a 90-day reporting period. But July 1st is the last day to start your 90-day reporting period to earn your 24 meaningful use incentive and avoid the 2015 and 2016 payment adjustments. Now, the crystal ball gazing, I was asked to think about the future a little bit here, and I think that for those of you really interested in where the future lies, I would suggest that you you pay a little attention to what's going on in Congress right now with the bill that was introduced, passed out of committee last week, I think on Friday, to repeal the sustainable growth rate. As most of you probably know, this has been a huge issue for most physicians. They're not happy with the sustainable growth rate, but it is in place until Congress does something to repeal it. For the first time, it looks like we may be closer to getting that may actually occur. But the bill is kind of interesting because it not only would do that, but it would merge these all the programs I'm talking about basically into one Medicare incentive program. And I think if like I say, if you want to see where the future lies, I think that tells you at least what Congress is thinking about. And this really is, where we go in the future really is a congressional issue. So even if this bill doesn't pass, I think it gives us an idea of what they're thinking. And I won't get myself into trouble by speculating beyond that. I was asked to talk a little bit about ICD-10 implementation. I think the main thing I need to tell you is this date here, and tell you we are not expecting to extend this again. I know there's lots of people wanting us to. There's lots of talk about this, but there is no indication that the date is going to be extended. We have a lot of information on our website trying to help practices get ready. This is just a very simple diagram of steps you might want to take, starting with talking to your software vendor if you have one. Many of you I know use clearinghouses or billing services. Talk to them and your payers. Make sure that they have the ICD-10 upgrades completed so that you can begin your testing with their upgrades and identify the changes that your practice needs to make to convert to the ICD-10 code set. There's likely to be staff training needs, and you need to get that done so that you can really conduct internal testing and training, making sure that you can generate your transactions with these new codes before October 1st. Where we have a number of different tables like this, but this one is for small to medium practices, just sort of giving people a suggested timeline. Everyone does things different, but we're here in February 2014 right now. So according to this diagram, planning would have occurred. Most of the communication with your vendors, et cetera, should have occurred. There would have been some testing internally already, and now moving on to external testing and training for documentation and coding, because this is, very different in terms of the coding that needs to be done and what your coders need to know, for example, about anatomy and physiology, because there's so much more specificity with the ICD-10. We have a lot more resources on our website. The website's given here. We have fact sheets, we have implementation guides, timelines like the one I showed you, and even checklists for practices to follow. So if you haven't taken a look at that and you're maybe a little bit behind the ball on this, you might want to take a look at that website and use some of those resources. I'm going to stop talking here in just a minute to take your questions, but before I do, I just want to drive home the point that these programs, the Physician Quality Reporting System, e-prescribing, electronic health record, value modifier, are all separate programs as required currently under law. Each of them has separate criteria for what you need to do to receive the incentive, to avoid the payment adjustment. You need to pay attention to both of those and take steps now, because we really don't. At CMS, we really don't want to penalize you. We want to see you get the maximum incentives. And finally, do face the facts, whether you like it or not, that ICD-10 is around the corner, and don't be caught off guard on October 1st. I'm going to stop there. I do have, I'm going to go through a couple of these slides so that you can see some of your resources as we answer questions. But here's my contact information. Email is generally better than phone. John Langmead, who is a healthcare specialist, health insurance specialist, is with me in the room and will help answer questions. Dikon Chen and Lolita Jacoby both work in our financial management group and are actually the leads for any of the programs that are really tagged to the physician fee schedule, so the PQRS, the e-prescribing, EHR value modifier, so they can help with any of those as well as the ICD-10. And I think Dustin, we can open it for questions. I am going to go through a couple of slides here so you'll see what's available. And Dustin, correct me if I'm wrong, but I think we can send these out to folks as a PDF.
Absolutely, yes. That would be wonderful. PDF format. We can send a link to view this. And if there are any questions, you can please just type them into the GoToWebinar interface tool. And I took a couple notes here, but I really thought the ICD-10 timeline graph that you just showed was extremely insightful and helpful as far as the progress and where we're at right now. And you also mentioned that March 31st has been extended as the new EHR incentive date. That's correct? March 31st?
Yes, it is.
Okay. We do have one question that has arrived. What is the value modifier you are talking about? So I guess further detail on what the value modifier is.
Right, and I'm not surprised to hear that question. When I talk to physicians and practices and ask them about this, it's only about a quarter of practices seem to be aware, at least of smaller practices. So the value modifier was a provision of the Affordable Care Act that is really, if you think about why did Congress want us to have electronic health records or this physician quality reporting system? It's not just to have an electronic health record or reporting system, it's to actually improve care. And so now Congress has given us a new kind of tool in that armamentarium, which is not only seeing if you can report, but tracking how good the quality is as well as the cost, utilization of resources or cost. So we are required by Congress, CMS is required by Congress to apply this value modifier to payments made under the physician fee schedule, that is Part B payments, starting with the large groups, as I talked about, the 100 or more eligible professionals in 2015, but to groups of 10 or more in 2016, and all physicians in 2017. So this is, it is what the name says. It's actually value-based payment modifier, so it will be a modifier to all physician-based payments if you meet those group sizes as we roll this out.
Okay, another member has asked to pass on a thank you to you, so thank you. The next question that's come through, if we have 10 docs, do all have to participate or will the group be penalized?
Can that person tell me what we're talking about participating in, the value modifier or PQRS?
Okay, well, let them submit another response to that through the interface. While we wait for that response to come through, another question is, we no longer need to code ERX G8553 on 2014 claims?
I am pretty certain that the answer is no. John's going to look that up to be certain, but I think that G code has basically gone away as of 2013, at the end of 2013. But we're looking that up right now.
Okay, very well. I haven't seen another note come through from the. Oh, there it is. Just she said both. In answer to your question on the other member, the answer is both.
Okay, so and she said it's 10 EPs exactly.
Let's see here.
Is that what the first note? We'll just assume it's 10, not 9.
Sure, that sounds good.
So the value modifier will not apply this year to groups of 10 or more. In 2016, it will. Okay, so that's it for the value modifier. For the PQRS, they can choose to report as individuals or as a group, but they will have to meet the criteria either way. That is that 50% of you have to choose your measures, okay? And we just don't have time to go into all of this. But for 2014, one thing you should know is the measurement selection process has changed. You now have to choose, if you're using individual measures, it now has to be 9 measures over at least 3 of there are 6 domains. Those domains being sort of different aspects of care that follow something called the National Quality Strategy. So the framework is very nice, but it's new for you all you have to choose 9 measures over 3 domains unless there are not enough measures that actually apply. If you're in certain subspecialties, you may not have 9 measures. And then you have to report on, I think it's 50% of the eligible encounters for those measures. So that is the requirement for groups of 10 or more. Now, if you're an individual, if you're in a small group, you can still choose to report as a group, but you don't have to. You can report as an individual either way, and you're not held quite to the same standard at this point.
Okay.
And John, I think, has an answer about the G code for the e-prescribing.
Hi, everybody. This is John Langmead with CMS. To go back to the previous question about G code G8553 and the need to report it for the e-prescribing program. So to answer that, you do not need to report that anymore. The e-prescribing incentive program ended in 2013, so there's no need to report that G code anymore for the purposes of that program. E-prescribing now is only part of the EHR incentive program, so you would just have to meet the requirements for e-prescribing under that, which does not involve the reporting of that G code. If you need something in writing, you can certainly send us an email. It's also on our website as well. So.
And that's sort of the evolution of these programs. You know, I said that don't mistake when I said the kind of difficulties of them being from different pieces of legislation. It wasn't Congress did build them upon one another. So PQRS initially had e-prescribing within it, and then Congress said, no, we really want to push e-prescribing, so they made a separate e-prescribing program, and in fact that is felt to be so important that it's one of the main core things within the EHR. So this is an evolution as we move towards it, but there is, like I said, the framework and the development of it actually does make a lot of sense, but sometimes when you're in the trenches trying to report it, I know it doesn't always feel that way.
We've got a couple more questions if you have time, Dr. Thompson.
Sure.
Okay. Next question. Will my ocular plastics doctor be able to be exempted with some of the PQRS measures that do not apply to his scope of practice?
Well, it's not exactly like you get exempted. You need to look at it and see if which ones might apply. I'm guessing that you won't find 9. I'm not sure how many you will. But you report which ones are applicable, which ones you do have patients that meet the criteria for the denominator. Of course, it's a lot easier if you're primary care or certain, say, internal medicine specialties or even surgical specialties to have a plethora of measures to choose from, and then certain subspecialists are not even going to be able to have 9, and that's okay as long as they really don't apply to you.
Wonderful. I just also want to point out that physician partners will get info to our members on the value modifier. So I know that's a lot of information that you covered, and you're going to pass on the slides, which we really appreciate, but we'll also pass on some more information. But actually, that seems to cover everything right now. We really appreciate you doing this today, Dr. Thompson and Mr. Langmead. Thank you very much.
All right. Thank you.
Okay. Have a great day, everybody. Thank you for attending. Bye-bye.
Bye-bye.